Okay, so we will discuss the sports injuries, hand and wrist. Um, First of all, you should know that there are many injuries which can cause the wrist, which can cause the pain, or which can cause some discomfort symptoms in the wrist and hand. Uh, and there are many injuries which can cause acute wrist pain. Some can cause the subacute, or some injuries that can cause the chronic symptoms in the wrist and hand. Those who are chronic, usually they are the atraumatic or injuries, while the acute injuries, they are mostly traumatic. So we will not discuss all of them. We will just go towards some specific uh, injuries to the wrist and hand, specifically in the radial wrist injuries. We will discuss the scaphoid fracture, which is one of the most common um, injury to the wrist, and along with uh, the radial radial injury as well, but the radial injury as compared to the scaphoid is less common. So we will discuss these two and the wrist injuries, and then we will go towards the other common hand injuries. So this lectures, most of the contents, Dr. Seema, she have helped me a lot in the preparation of this lecture. So thanks and credit goes to the Dr. Seema. She is the lecturer there in the Khyber America University, Peshawar. Approximately 20% of all sports-related injuries that involve the wrist and hand, and these sports injuries they may occur at the every level. Either it is at the high school or at the collegiate athletes, or it may be in the general population who are involved in the recreational sports activities. Uh, the basic mechanism for that scaphoid fracture or the radial fracture, or that inicarpal bone in the wrist. This is the that injury which is we can call as the fush injury, or some we can call as fall on the outstretched hand. And the mechanism, if we elaborate this mechanism, so basically there is hyperextension of the wrist as well as the uh, forearm is pronated, and there is radial deviation. And the combination of these three mechanisms, that hyperextension of the wrist, that is the forearm pronation, and the radial deviation, they will make this scaphoid fracture or other carpal bones prone towards the fracture. Among the carpal bones fracture, the on the radial side, the scaphoid fracture is the most common, and this injury is in the literature it is being revealed that it's more common in female as compared to the male. So different sports which involve in which have the risk of falling on the outstretched hand with this mechanism, hyperextension, pronation, and radial deviation, will increase the risk of this scaphoid fracture. So these are the some of the sports activities, different sports in which the mechanism has been there. If we look at the picture on the top on the left side, there's the baseball, and the person who is running, he has been slipped and tried to reach the line, and he has been fall with the pronated radial deviated and the hyperextended wrist, which is the mechanism for that risky mechanism for the scaphoid fracture. Similarly, this is the another player from the Gradiron, which is that American football. The person which ball in the hand, he is trying to reach that line, the opponent line, which is scored as a point. But if we look at his hand, which is on the ground, this is with the extension, and we can say that hyperextension. And as well as if we look at, there is some radial deviation as well, and pronation as well. So this mechanism that will make this person very prone towards the spine fracture. Similarly, here is some other collegiate level soccer sports game in which the person, she is just going to fall, and with that mechanism if we discussed. On the other hand, the cricket fielder, that the captain of the English team, that Lester Cook, he is catching a ball on the right hand, but if we look at the left hand, it's going to fall and he's to hit the ground with that mechanism which we discussed, which is the mechanism injury for the scaphoid fracture. So it means many sports in which there is chances of falling, in which there is um, mechanism of injury, the repetition of such activities which involve that falling on the outside hand with pronation of the forearm, with hyperextension of the wrist, and that radial deviation of the wrist, they will increase the chances of the scaphoid fracture. The signing symptoms after the fracture, the athletes, he or she will complain of some radial side wrist pain. Uh, and this pain will be more common and more sharp and intense at the anatomical snub box. So that will be exquisite tenderness. That means sharp tenderness, intense tenderness, very keen tenderness, specifically at the anatomical snub box. Now, what is anatomical snub? The snub box. That is also known as the radial fossa, and this is uh, as we look at in the picture below, there is an anatomical snub box. This anatomical snub box are the it is a triangular which is space which uh, as we can say there is a deepening on the radial side and not on the radial side. More specifically, it is on the radial dorsal aspect of the hand at the level of that carpal bones, and specifically which carpal bones, the scaphoid and the trapezium, these they make the floor of the snub box, and that's why when there is a scaphoid fracture, um, the this anatomical snub box will be having very intense and exquisite tenderness. The tendons which make this snub box, that is the medial border, that is being the tendon of the extensor pollicis longus, which we can say that the ulnar side, while the radial borders they are made by the two tendons, that is the extensor pollicis brevis as well as the abductor pollicis longus. So the deepening at that fossa, which is between these two sets, one is the that extensor pollicis longus, which is on the ulnar side, and the one which is on the radial side. This is the that extensor pollicis longus and the extensor pollicis brevis as a abductor pollicis longus. So that deepening, they will have intense tenderness. There is initial fracture. Similarly, another test which will be positive, that is the axial loading on the thumb. This axial loading, this is also positive when the person have osteoarthritis of that area. But if there is no such OA, then if the therapist will apply some axial loading to the thumb, again, it will be very painful and the patient will have some problem and some pain when there is application of the axial loading. Another symptom that will be very painful, the patient may unable to do that pincer grasp. Pincer grasp, which is sometimes also known as the pincer grip. This pincer grip or pincer grasp that refers to the action of closing the thumb and the index finger together in order to hold an object. Um, if we look at the picture on the top right, the person is doing that pencil grasp. He is holding, or she is holding the index finger of the other person with the two hands. And this combination of the index finger as well as the thumb to hold some object, it is known as the pencil grasp, or we can say that the pencil grip. This pencil graph, this is also a milestone in the development baby, and a baby will typically develop this skill between the age of 9 and 10 months. But there is still a variation in the rate of this presence of this graph. So usually the sign and symptoms, so I'm going to repeat and summarize them. They will be a radial side wrist pain and sharp and very intense tenderness, specifically at the anatomical snub box. There will be axial loading of the thumb. They will be very painful, and as well as the patient will have some problem or some pain when he or she is tried to do some pencil grip or the pencil grasp. Radiological assessment, this is very necessary. But most of the time, the scaphoid fracture, that is a very subtle uh, problem, and it's very difficult to identify the scaphoid fracture on that simple review. But we can take the help of the CT scan, and that CT scan will confirm and that will clarify and easily identify the fracture if there is on the scaphoid. If we look at this on the right side, the radiograph, you can see clearly that the bone which is on the top of the that radial side, this is the scaphoid, and this scaphoid, this is having some fracture. There is a transverse line, a black line, which you can see easily. This is that fracture. The different radios we can use for that scaphoid fracture, and simple specific views are as well, which are known as the scaphoid views. So the scaphoid views, that is a PA variation, are the different version of the PA in which there is some clenching of the fist as well. Other views as well, we can use them. So these radiographs, they include a posterior interior PA view, that include the lateral and ulnar deviated view. But usually there is a subtle line, subtle, which means which is very difficult to identify. Yeah, which is very delicate to recognize something on the radiographs and the MR images or on the CT scan. That finding, that is known as the subtle finding. So that is subalignment mean, which is very difficult and delicate to identify. Difficult to look at undisplaced fracture due to the irregular contour of the scaphoid bone, and that's why the CT scan can help us to identify if there is any um, fracture, if there is any problem which is goes unidentified on the simple radiographs. Um, MRI, they can be used, and that is superior to the CT scan in that sense. We can also visualize, we can also assess if there is any soft tissue injury as well through MRI, but CT scan usually that can identify any soft tissue injuries. So MRI, that will also not only give us the assessment and that image of that fracture bone, but the MRI will also give as the surrounding soft tissue injury if there is. Another best, which is more superior to the MRI and CT scan radiograph, this is the arthroscopy. The arthroscopy, that can be very modern and routinely used, most commonly used, just to identify if there is any very delicate or subtle injury. Arthrogram, that has a very low sensitivity and specificity. That's why there is no such common use of the arthrographs. So that was all about the radiographic assessment. So we can use all these CT scan, MRI, and as well as the radiograph. But still, as we discussed, that we can use some different and some specific views, which are simply known as the scaphoid series, the scaphoid views, and these include the simple posterior interior view, and that is just the position of the hand on the cassette of the X-ray. And we can see here, this is the scaphoid bone, which is on the exact radial side, and this is actually the scaphoid is that bone which connecting the proximal row and with bridging the proximal row with the distal row. And this is another scaphoid view which is known as the that PA with the ulnar deviation, as we discussed in the previous slide, that we can use that ulnar deviated lateral and ulnar deviated view. So this is the posterior interior with the ulnar deviation view, and that will be look like this one. We can also have that lateral view, which is the hand will be placed on their placed like that, and we can also have some semi-pronated oblique line as well. So all these are the specific views which can be used for the radiographic identification of the scaphoid fracture. Another thing which we can assess and we can observe, that is known as the gilula arcs, or known as the gilula lines. Basically, these are three lines which are present, which can be observed, which can be seen on the PA radiograph, and these are the initial line, which is on the marked by the bones, the scaphoid bone, the lunate bone, and that the other third bone on the ulnar side. Their proximal borders, they will make uh, this line, which is known as the guinular line 1. The same bones, their distal concave arc, they will make the gilula line 2, while the hemate and the capitate, their proximal convex arc, they will make that gilula line 3. So these three lines, they are very helpful when you are going to observe, when you are going to interpret the normal PA view. If there is no smoothness, or if there is no such curves, there discontinuation of this, as we can say that the disruption of these arcs, then there it means there is something wrong. There may be a dislocation of inner carpal bone, there may be subluxation or the rotative subluxation of some carpal bone, as we can see, if there is some fracture to the any of these bones. So these are these three lines which can be observed on the PA glides. Another injury which is very common in the elite young gymnast, those who are still in the under developmental stage, still when they have that epiphysis in their long bones. So the scaphoid fracture, beside the scaphoid fracture, this radial epiphysis that may be injured when they fall on the outstretched hand, which is known as the fush, that is the fall onto an outstretched hand. Usually, there is the displacement of the fracture and the epiphysis and that long bone of the radius. We can see here in this radiograph. This fracture, that can be classified according to the Salter and Harris. This is the normal radial side. The type 1, when the fracture is exactly straight and above that epiphysis, which is a growth plate. The type 2, which is the fracture of that radius which is above the growth plate, and the type 3, that when the growth plate injury, the fracture is below the growth plate or distal to the that growth plate. And the type 4, which is the combination of the type 2 and type 3, there is fracture both above the growth plate or proximal to the growth plate, as well as there is fracture distal or below that growth plate. Usually, when there is narrowing of this growth plate on the radiograph, that specifically mean that there is some Salton Harris type 5 fracture. Because if we look at this type 5 fracture, usually there is no such growth plate, and there is being disrupted of that growth plate. So that radial fracture, that can be classified into this type 1, type 2, 3 up to type 5. The rehabilitation protocol to the scaphoid fracture, that those fracture which are treated closely, which mean the non-operative management, and the treatment is just that cast, which is known as the thumb speaker cast, or we can call as the sugar tongue thumb speaker cast. And both we can be used the single sugar thumb speaker cast, or the double sugar tongue thumb that speaker cast. Usually, this cast is being present and being applied to the patient, with keeping the wrist at least 20 to 30-degree extension. So you should remember this point, that usually the wrist is kept an extension with 20 to 30 degree. And one more thing to be remembered, that that distal boundaries, the distal end of this cast is just proximal to that metacarpal peningeal in joint, which is the MCP joints. So it means the MCP joint, they will be free to move. Like you can see the top right picture, in which there is a white cast on that patient left forearm. So the MCP joints, they will be free, and sometimes it is also that the PIP joints, the proximal interphalangeal joint are the interphalangeal joints. They will be also free, but in the thumb, the interphalangeal joint they will be free, like we can see here in this picture. So the initial 0 to 6 week, it means that is almost 1.5 month rehabilitation that simply involve that wearing of that cast as well as some active range of motion exercises to the shoulder region, the active shoulder active range of motion exercises to the MCP, that is the metacarpal phalangeal joint, the proximal interphalangeal joint, and the distal interphalangeal joint uh, from the second to the fifth. As the first one that may be present inside the cast, so the active and one more thing, if there is out of the cast again, there will be no such active movement to the thumb side because this is the radial side, and the fracture of the scaphoid may become worse and may become displaced again, and may have some symptoms again if there is active range of motion exercises to the thumb. So these active range of motion exercises to the MCP, PIP, and DAP should be given to the second to the fifth. It means from that index finger to the small finger, exercise should be given in the initial phase, which is from 0 to 6 weeks. So this is exactly the replication of that sugar thumb speaker cast to a patient on her left side forearm. Some different exercise that should also be prescribed in the initial phase of this patient in the rehabilitation. There is the side lying external rotation, the shoulder extension, and as well as the external rotation, which is known as the 99 external rotation, and the prone horizontal abduction. And the side lying external rotation, and the patient will lie on the uninvolved side with involved arm and side with a small pillow between arm and body, keeping that elbow involved, arm bent and fixed to side. The rise arm into external rotation, slowly lower to starting position, and again repeat this activity. And should be kept in mind that the towel or any roll that should be present between the body and the elbow just to have that external rotation of that arm. Similarly, there may be the shoulder external rotation extension as well, in which the patient will be lie on supine and their stomach, and their involved side they will be hanging up the table towards the floor, while the thumb will be pointed outward. It means that will be an external rotation. Then the patient will rise the arm straight back to extension towards their hip, and then again slowly they will bring back to its own original position, initial position, and they will repeat this activity. So he or she will do that extension of the shoulder joint. In the prone horizontal abduction, similarly, these exercises also have been present here. Uh, the second phase, which is 6 to 12 weeks, that is the bony union. In this phase of rehabilitation, usually the that area this is not tended to palpation, and as well as penis range of motion when the cast is removed. So a short arm thumb speaker cast should be still present there and should be prescribed for to the patient, as we can see in the picture on the top right of the slide. Um, the shoulder and the finger exercises, which we have discussed and which were continued in the initial phase, that should be continued. Begin the active range of motion exercises for the elbow flexion, extension, supination, and pronation. That should also be started in this phase. At the 12-week CT scan or the PA glide scaphoid view, they can be used just to confirm that union. And if it is confirmed by the radiographic different images, then it is known as there is also the radiological union. So if there is no union which has been identified on the radiograph, so it should be the exercises and the class that should be continued for again 2 3 weeks. But again, after the second time application of the cast, After the second cast, again, if there is no such radiographic union, then the third time or fourth time wearing identification of that cast, that will have no sub beneficial, and it's been reported and revealed by the literature different articles that there will be no such benefits on when the patient will wear the third or fourth times. So these are the different exercises which will be prescribed to the patient from 12 to 14 weeks. And usually in this, there will be the speak up plans that will be removed, and different home exercise that should be prescribed in their home plan. The patient should receive the active general assisted wrist flexion extension exercises. There should be active general assisted wrist radial and ulnar deviation range of motion exercises. And similarly, the thumb, which was not initialized in the initial phase, that active or general assisted MCP or the interphalangeal joint of the thumb, that should also be started to the patient. So we can see here the different exercises that have been, that is flexion and extension, radial and ulnar deviation, and the pronation and the supination. And these are the other different exercises which can be prescribed in the home exercise plan to the patient, to the athletes having some scaphoid fracture or having some other fracture as well in the carpal bones. This is the phase which is after the 14 and 18 weeks. If there is any splints, all type of splint that should be removed. There should be discontinuation to the all splinting. And there should be some occupational therapy added as well. Active and aggressive exercises to the all flexion extension, radial ulnar, and the other thumb exercises. After the 18 weeks, some grip strengthening and aggressive range of motion exercise should be prescribed, as well as some unrestricted activities, exercises like we can see here on the left side, that some TheraBand or some device can be used just for that, providing that resistance. So the focus should be on the strengthening of the different muscles that we involved, as well as the focus should be on the fine movements, as well as that different range of motion of the thumb as well. If that there is unstable and significantly displaced fracture which is being identified on the image and the radiograph, so it can be treated with the surgical fixation. And you can see here in this slide that a screw has been provided there within that scaphoid. Just this is that surgical internal fixation of those. So surgical treatment they may be prescribed if the patient is giving no response to the conservative treatment, to the splinting, to the other physical therapy exercises. So the mallet finger deformity that will be discussed in the next lecture. That was enough for today. So we discussed the different mechanism of injury, as well as the sign and symptom, and then some rehabilitation and treatment, as well as some radiographic views and radiographic discussion about the scaphoid fracture, which is very common and one of the most common fracture bone in the athletes.